Thank you for your kind introduction. And can you see my slide? Okay, thank you.
Yes, perfect. Thank you.
Thank you. Yeah, I'm Jaekyung Cheon from Korea, and I'm a medical oncologist, and my area of interest is clinical researches in HCC, biliary tract cancer, and pancreatic cancer. So today's topic is systemic therapy against combined HCC and cholangiocarcinoma, and I will talk about only confined to combined HCC and cholangiocarcinoma. So I will review real-world evidences and recent studies about genetic alterations of combined HCC and CCA, and I will talk about clinical trials briefly. So as you know, combined HCC-CCA is a type of primary liver cancer, and it is very rare that accounts for less than 5% of primary hepatic tumors. And it is known to be, it is diagnosed at advanced stage. And it is known to have aggressive behavior and poorer prognosis compared to even HCC or cholangiocarcinoma. But as you know, it is very rare cancer, so there is no established guideline or global consensus for optimal treatment. And in clinical trials for HCC or cholangiocarcinoma, the combined HCC-CCA have been excluded. So for these reasons, there have been a large unmet needs in treatment of patients with combined HCC cholangiocarcinoma. So as I mentioned, there's no guidelines and there was no prospective studies for this population. So I will show you the retrospective studies to better understand this population. So there were 4 retrospective studies about systemic treatment for combined HCC and CCA patients. So I will show you one by one. The first one is single center study from United States. So between 1999 to 2016, a total of 68 patients who received systemic treatment were analyzed. In this study, patients mainly received gemcitabine-based chemotherapy, and the response rate was 24%, and the median overall survival was 11.5 months in gemcitabine platinum group. And in gemcitabine 5-FU combination group, the response rate was 15% and median OS was 11.7 months. In sorafenib group, there was no responders and the median overall survival was reported as 9.6 months. The second one is from France. Between 2008 to 2017, the 30 patients were included in this analysis, and all patients received gemcitabine-based chemotherapy. And gemcitabine oxaliplatin with or without bevacizumab and gemcitabine cisplatin group, the response rate was about 30%, and the median overall survival was reported to be 6.16 months. And in the multivariate analysis for overall survivor, synchronous metastasis, higher bilirubin level, and positive serology for viral hepatitis were significant independent poor prognostic factors for overall survivor. However, it was a retrospective study of very small number of patients, so the interpretation should be cautious. And the third one is from Japan. It was multi-center retrospective study, and a total of 36 patients were included in this analysis. And patients received cytotoxic chemotherapy or sorafenib and other investigational drugs. And in this study, the response rate for each group was not reported, but the overall response rate was only 5%, and the median overall survivor was over 10 months in cytotoxic chemotherapy group, and only 3.5 months in sorafenib group, but only 5 patients received sorafenib. And in this study, the multivariate analysis to find prognosis factors for the survivor was also conducted, and equal performance status 1 versus 0, and sorafenib group was related poorer overall survivor. But as I mentioned, we should interpret this data cautiously, especially for the prognostic factors, because only 5 patients received sorafenib. And the last real-world data is from South Korea, and from 1999 and 2015, a total of 99 patients were included in this study. And among all patients, 37 patients received cytotoxic chemotherapy, and 62 patients received sorafenib as first-line systemic treatment. The response rate was about 20% in platinum-containing cytotoxic chemotherapy group, while it was less than 10% in sorafenib group. And different from the Japanese data, the overall survivors were similar, about in 10 months in every patient, as regardless of cytotoxic chemotherapy or sorafenib. And in the multivariate analysis, extensive intrahepatic tumor burden and elevated bilirubin level were significant prognostic factors for poor overall survivor. So taken together of these real-world data, the efficacy of cytotoxic chemotherapy and sorafenib were not significantly different, and the median overall survivors was about 11 months throughout the studies, and the poor prognostic factors were related with poor performance, higher bilirubin level, and more tumor burden, and maybe related viral status. And recently, to better understand the biology of this patient population, genomic alterations of this group were analyzed, and these slides were already shown by Professor Sia. And in a study of Asia, it was about 133 patients, and the authors performed genomic and transcriptomic sequencing. And in this study, TP53, TERT promoter, and axin-1 were the most common genetic alteration of combined HCC and cholangiocarcinoma patients. And these were not druggable mutation. We don't have any targeted agent for this. And in this article, the authors performed transcriptomic sequencing, and they divided patients into 4 clusters through P1 to P4. Cluster P1 was similar with cholangiocarcinoma and more KRAS mutation or IDH1 mutation like intrahepatic cholangiocarcinoma. And in P2, TP53 mutation were more frequent, and it was related with higher apoptoprotein level. And P3 was associated with TGF-beta pathway, and P4 was related beta-catenin 1 mutation. And survivor analysis was also done, and it revealed that the prognosis of patients in P1 and P2 were poorer than those in P3 and P4 group. In another recent analysis from United States, the researchers just performed targeted sequencing and used machine learning classification. And about 75 patients in this study were classified as cholangiocarcinoma associated group, or 58% of patients were classified as HCC associated group on the basis of genomic profiles. Cholangiocarcinoma associated group sets had more ARID1 mutation and FGFR2 and IDH1 mutations, and the HCC resembling cases harbored TERT, beta-catenin 1, and MYC mutations. So in patients with combined HCC and cholangiocarcinoma, genetic alterations were most common in TP53, TERT, and AXIN1 and PTEN. And I think the HCC combined HCC cholangiocarcinoma cases may be classified resembling either cholangiocarcinoma-like group or HCC-like group, even we don't know a lot of things about this. And this is the last section, and I will show you briefly. In HCC, immune checkpoint inhibitor monotherapy or combination therapy showed 20 to 30% of response rate and 15 to 12 months, 15 to 20 months of median OS as first-line treatment. So immunotherapy showed promising efficacy in advanced HCC patients, and this combination of atezolizumab plus bevacizumab is established first-line therapy throughout every guidelines. Anyway, however, in cholangiocarcinoma, immunotherapy mono or combinations showed around 15% of response rate as later line systemic treatment. And as combined HCC cholangio is very rare, and as I mentioned, we can't perform prospective study for this patient population alone. So we'd better find other targets in basket trials for many kinds of malignancies. So for example, in MSI high cancer patients, pembrolizumab monotherapy for the patients after standard treatment failure showed promising activity with response rate of 34% and durable responses, and the median overall survival was 23 months. But the prevalence of MSI high or deficient MMR tumor is known to be less than 5%. And like MSI high, TMB high is known to be one of the possible targets for immunotherapy. And in Keynote 158 study, pembrolizumab showed promising activity and durable response in TMB high tumors among various tumor types. But the prevalence of TMB high tumor is also very well less than 5%. And NTRK fusion is known to be very, very rare, is less than 1%. However, in patients with NTRK fusion mutation, it is known that the targeted agent shows very favorable responses, and the targeted agents, including lalotrectinib, were approved from FDA, and other agents are also undergoing clinical trials. So even it's very rare, but to find targets, I request pathologists more further immunohistochemistry for the MMR, and I always do the NGS study for all combined HCC-CCA patients. But regarding that, the turnaround time of NGS about 4 weeks, I should make decision either HCC-directed systemic therapy or cholangio-directed cytotoxic chemotherapy. So I think the active discussion with my colleagues, including radiologists or pathologists, is very important to make treatment decision, and also multidisciplinary approach is very important. This is the last slide. So combined HCC and CCA is very rare malignancies, and there is no global consensus and guidelines for systemic therapy for unresectable combined HCC and CCA. In previous real-world data, cytotoxic chemotherapy and sorafenib showed modest efficacy in patients with this group, with median OS of about 11 months. And genetic alterations reveals distinct subtypes, and further studies are needed to find the proper targets and more optimal treatment for this group. Thank you for your attention.
Thank you very much for your very interesting talk. I don't know whether there are questions from the audience.
I have a small question.
Yes, Juliana.
First of all, thank you very much for the nice talk, and for having given data on classical chemotherapy. You know, compared to sorafenib, to TKA inhibitors, which gave similar results, overall survival. So my question is, what do you think about the dosage of 5FU? Because these are old data. Maybe they use just low dose 5FU. So
Mm, hmm. But actually, I don't use 5FU for this group. I usually prescribe gemcitabine and cisplatin combination. So I don't know about the dose relationship of 5FU and efficacy.
okay, but you know I understand that nobody thinks about 5FU is very cheap. There is no company behind that. But
Yeah.
if you use the proper amount of 5FU, you may get nice results, maybe without toxicity. Of course, it's eliminated in the liver, 5FU. So you may, you know, if you have a really cirrhotic patients, you may not use it. But sorafenib is also chemotherapeutic. So, you know, we make a difference, but these are all chemotherapeutics. I just want to stress the point that if you are, you know, hopeless, just take 5FU.
Okay.
Okay.
Yeah, it's probably good advice. Yeah.